So students, question number 1. True regarding adenomyosis is more common in nullipara. Estrogens are the agents of choice for medical management. Presents with menorrhagia, dysmenorrhea and enlarged uterus. More common in young women. So true. This is not true. This is in multiparous lady around age of 40 to 50. Estrogen are the agent of choice. No. Treatment is the progesterone. Present with menorrhagia, dysmenorrhea and enlarged uterus. True. This is true. More common in young women. No. So adenomyosis, multiparous woman rather than nulliparous lady, affect in the late age group, that is 40 to 50 years. Estrogen stimulate the growth of adenomyotic tissue and worsen the symptom. So treatment is LNG-IUS, progestin, OC pills or GnRH agonist. And its presentation is menorrhagia, that is heavy bleeding, progressive dysmenorrhea, that is painful menstruation, or uniformly enlarged boggy tender uterus. Adenomyosis मिडिल एजेड वुमेन में दिखाई देता है, स्पेशली बिटवीन 40 and 50 years. Less common in younger women. So the key point is adenomyosis seen in multiparous women along with symptoms like menorrhagia, dysmenorrhea and enlarged uterus. Next question. Question 2. A woman develops secondary amenorrhea following postpartum curettage. Progesterone challenge test and combined estrogen and progesterone test both failed to produce uteral bleeding. What is the most likely diagnosis? So if any case of secondary amenorrhea come, first is to do UPT. First you have to rule out pregnancy. Second is progesterone challenge test. To give progesterone withdrawal. If there is an ovulation, then there will be low progesterone. So there will be high estrogen. So when you give progesterone withdrawal test, then it will bleed. If does not bleed in progesterone challenge test, then to give combined estrogen and progesterone test. If it bleeds, then there is shortage of estrogen. So in this case, there is second amenorrhea following postpartum curettage. So postpartum curettage will destroy the endometrial basal layer. That will lead to adhesion. So diagnosis will be Asherman syndrome. Okay. In PCOS, secondary amenorrhea occurs, but the cause is chronic anovulation, not significant history of any curettage. It is due to chronic anovulation. Withdrawal bleeding usually occurs after progesterone administration. Because PCOS there is anovulation, there will be excess estrogen. So when you will give progesterone and then withdrawal, then it will bleed. Premature ovarian failure. Age group is less than 40 years. Rest FSH value of 40, and we have to repeat after 4 weeks for confirmation of the diagnosis. So it is not associated with intrauterine adhesion. Asherman syndrome, it is an acquired condition characterized by intrauterine adhesion resulting from damage to the basal layer of the endometrium, most commonly following postpartum curettage. Typically present with hypomenorrhea or secondary amenorrhea. Failure of withdrawal bleeding, both progesterone withdrawal and combined E plus P, suggest an end organ defect, that is defect at uterus level, commonly due to the Asherman syndrome. So diagnosis of choice is the hysteroscopy and management choice is hysteroscopy guided adhesiolysis. Hyperprolactinemia causes amenorrhea by suppressing the GnRH secretion, leading to decreased gonadotropin levels, not associated with intrauterine adhesion. So most common uterine cause of secondary amenorrhea is Asherman syndrome. First you have to rule out pregnancy, then most common is PCOS, but when it comes to the uterine cause, it is the Asherman syndrome. Most common cause of Asherman syndrome is the curettage. FSH and LH level usually normal, and gold standard diagnosis is hysteroscopy, and treatment is hysteroscopic adhesiolysis, followed by, to prevent the adhesion, we have to give estrogen therapy or IUCD placement. Question number 3. A 42-year-old man is undergoing TH for symptomatic fibroid. While ligating the uterine artery, the surgeons take special care to avoid injury to a structure that passes beneath the artery. So, what is the anatomical relationship? We all know under the bridge. What does it signify? So, above is the uterine artery, below the uterine artery is the ureter, and below that is the uterine vein. So, this is the water which is under the bridge. So answer is ureter passes below the uterine artery. It is the most common site of injury during abdominal hysterectomy. Okay. Ureter enters the base of the broad ligament and passes beneath the uterine artery approximately 1 to 2 cm lateral to the cervix. This is known as water under the bridge, and this is the commonest site of ureteric injury. So length of ureter is 25 cm. This is a retroperitoneal structure, lies on psoas major muscle, forms the posterior boundary of ovarian fossa. It passes beneath the uterine artery, then enters the tunnel of Warthem within the McEnroe ligament. It opens into the urinary bladder at the trigone, and this is the most common site of ureteric injury during gynecological surgery, that is abdominal hysterectomy. Next question. Question number 4. A 42-year-old perimenopausal woman present with history of amenorrhea for 3 months, followed by painless, profuse, prolonged uterine bleeding. She has no history of dysmenorrhea. If there is no dysmenorrhea, then endometriosis and adenomyosis are less likely. In fibroid uterus, there will be no such history of amenorrhea. Diagnosis: metropathia hemorrhagica. This is around perimenopausal women. So how to diagnose it? Metropathia hemorrhagica is a characteristic form of anovulatory dysfunctional uterine bleeding seen in perimenopausal age group, that is 40 to 45 years. It occurs due to the prolonged unopposed estrogen stimulation followed by estrogen withdrawal. The typical pattern is period of amenorrhea, absence of menses, followed by painless, profuse and prolonged bleeding. Absence of dysmenorrhea due to anovulatory cycle. If there is pain, that means it is an ovulatory cycle. So painless bleeding is an anovulatory cycle. Metropathia hemorrhagica. Age group is 40 to 45 years, around perimenopausal. Anovulatory. Cause is prolonged unopposed estrogen followed by estrogen withdrawal. And histopathology is typical finding of simple endometrial hyperplasia without atypia, that is Swiss cheese endometrium, and bleeding pattern is amenorrhea followed by painless, profuse, prolonged bleeding. Next question. Question number 5. Which of the following is the second generation endometrial ablation technique? So endometrial ablation technique is used for abnormal uterine bleeding to control AUB. So the question is second generation. You must know the first generation and second generation. In first generation, you require hysteroscopy. So there will be specimen for histopathology. In second generation, you don't require hysteroscopy. There will be no specimen, and this is an OPD based procedure. So out of these options, microwave endometrial ablation is the second generation ablation technique. So what are the first generation ablation technique? Endometrial laser ablation, transcervical resection of endometrium, roller ball electrocoagulation, and it requires hysteroscopy and distension media. In second generation endometrial ablation, example are thermal balloon ablation, microwave endometrial ablation, radiofrequency induced endometrial ablation, Novasure, that is electrode mesh, hydrothermal ablation, cryotherapy, and this is daycare procedure. You don't require hysteroscope or distension media. Next question. Question number 6. Which of the following statement regarding the combined hormonal transdermal contraceptive patch is false? It avoids fast pass metabolism in the liver. It is true. The approval transdermal patch is marketed as Ortho-Evra. This is true. One patch is applied and kept continuously for all 3 weeks. This is false. You have to apply one patch per week for 3 weeks. then patch free interval is 1 week. The patch should be applied on skin free of abrasions. This is true. Brand is the Ortho Evra and it contains ethinyl estradiol 20 microgram per day and norelgestromin 150 microgram per day. This can be a potential question. No fast pass hepatic metabolism. Apply on intact skin. Avoid brace. Change weekly for 3 weeks followed by 1 patch free week. If patch detaches more than 24 hours, apply a new patch and use backup contraception for the next 7 days. Next question. Question number 7. A woman presents within 72 hours of unprotected intercourse and requests emergency contraception. Which of the following emergency contraceptive methods has the lowest failure rate? Option A, USP regimen. This is wrong. This is having the highest failure rate. Levonorgestrel. This is most commonly used drug. Centromin. Option D is the copper IUCD. This is having lowest failure rate, that is less than 1%. USP regimen, that is both combined estrogen and progesterone. It has a failure rate of 3.2%. LNG, that is levonorgestrel. So the dose is a potential question. 1.5 mg single dose or 0.75 mg twice, 12 hours apart, 120 hours, that is 5 days after intercourse. And its failure rate is 1.1%. Centromin or ormeloxifene 60 mg in 2 doses, 12 hours apart, can be used and its failure rate is 1%. Whereas copper IUCD, this is the most effective emergency contraceptive method, having lowest failure rate of only 0.1 to 0.4%. So most effective is the copper IUCD. LNG and ulipristal acetate can be used up to 5 days. Dose of ulipristal acetate is 30 mg. Mifepristone dose for emergency contraception 100 mg. USP regimen has the highest failure rate. Next question, question number 8. The most common cause of precocious puberty. Most common cause is idiopathic. So cause can be divided into central cause, peripheral cause. Option A, gonadoblastoma is a rare gonadal tumor that may produce sex hormone and cause precocious puberty, but it is an uncommon cause. This is a peripheral cause of precocious puberty. Idiopathic central precocious puberty is the most common cause of precocious puberty. McCune-Albright syndrome. This is a cause of peripheral precocious puberty, triad of precocious puberty, cafe-au-lait spots and polyostotic fibrous dysplasia. However, it is less common. And in juvenile granulosa cell tumor, this secrete estrogen and that will cause isosexual precocious puberty. Most common cause is idiopathic. Most common pathological cause is hypothalamic hamartoma, that is a CNS tumor. McCune-Albright syndrome causes gonadotropin independent peripheral precocious puberty. Granulosa cell tumor causes estrogen excess and isosexual precocious puberty. Question number 9. According to the FIGO 2023 staging, CA endometrium metastasis to pelvic lymph node is classified as, it is 3C1. You have to remember the 2023 FIGO staging of CA endometrium. It's little bit of lengthy and confusing, but you have to remember the staging. So 3 in 3C, pelvic lymph node is the 3C1 and para-aortic lymph node is the 3C2. Next question 10. Which of the following is the preferred treatment in low-grade serous ovarian carcinoma? So in low-grade serous carcinoma, this is not chemosensitive. So you have to give hormonal therapy, that is of aromatase inhibitor. Whereas in high-grade serous carcinoma, it is chemosensitive. So you have to give chemotherapy, that is paclitaxel plus carboplatin. Thank you.